Hi, everybody. I want to thank you for joining us on this beautiful day outside. I'm looking outside my window and joining us for our fourth in the series of COVID and clinical care. And this is our fourth talk. And today we're going to have Dr. Dareen Elchar, who is excuse me, an early career investigator in maternal fetal medicine. She's going to be presenting on perinatal COVID-19. I think you guys can all see the slide right now. And I'm just going to give a bit of a bio. So she's an early career investigator in MFM, as she's a physician at the TOH, a clinical investigator at OHRI, and an assistant professor at the University of Ottawa. She's the co-lead of the COPE network, which was recently set up in response to the COVID-19 pandemic. She completed her residency in Ottawa in 2012. And in July of 2014, she completed her MFM fellowship training at the University of Toronto. She has a keen interest in obstetrical research and its impact on women's health. She joined the maternal fetal program in July of 2014, and she completed a master's in clinical epidemiology from Harvard. She is presently involved in some research that includes maternal health conditions and pregnancy outcomes, cesarean delivery by maternal request and provincial outcome, COVID-19 and pregnancy, particularly germane to today's talk, cannabis use in pregnancy, obesity and diabetes, maternal and neonatal obstetrical outcomes and interventions. She has funding through the CHR and has multiple grants through various grant agencies. And she's presented a lot of her research in many international conferences. And she's currently the program director for the Maternal Fetal Medicine Fellowship Program. So just before I turn it over to her, just a couple of housekeeping items. There will be a chat function. So if you do have questions, please enter them via the chat and I will keep monitoring them during the talk. And as the questions build up, we'll just interject into the presentation. Dr. Elchar wants to make this as interactive as possible in these live webinars. So if you do have questions, keep them coming and we'll make this as interactive as we can. So without further ado, I turn it over to Dr. Elchar.
Oh, yes, hi. So I'm just going to make sure, I think people can hear us. I know there's a 20-second delay on these events, but I'm getting the thumbs up, so that's great. Thank you for this introduction, and thank you for asking me to join these rounds. I think it's great that we're connecting and making sure to share all the different information. I say this every time I've given this talk, and believe it or not, even in the short time, I think it's the third or fourth time that it's evolved with the changing knowledge. I think every week there's something new that I'm like, oh, we need to add this and add that. And I say that I think none of us are really experts in what's going on right now with COVID-19. We're just experts in our own fields and applying that to what we're learning on this journey. And I think that we'll have all of the evidence and all of the story to tell once it's done, which is why the title of this slide is Evidence-Based Medicine, the Absence of Evidence. What do we know? What are we looking at? Because I stress every day when someone comes and shows me a new article or a new finding or a new, the ones I worry about are the media articles about how to treat this, is that a lot of this is very fast paced and a lot of this is not peer reviewed the way we're used to. So I think it's very important for us to take that into account when we're reading and interpreting. So that's just my plug on this, because I think someone tried to say that some people are becoming expert, and I feel like every time we do know something, we know less of other stuff. So just the slide I like to just kind of start off to, this is today. We're at 8,500,000 cases, 500,000 cases in the world, sadly, and 500,000 deaths almost reaching. This is a nice visual capitalist put out a slide of like, really, I keep trying to tell this to people around me and kids, like my kids, this isn't new. We've had pandemics before. This is just our modern world really living a bigger one than the SARS, Ebola, swine flu, MERS, somewhat Zika. And this is where COVID lies in terms of timeline and size of the deaths related to this pandemic as of yesterday. And so we're still going to see where it will evolve with regards to the rest of the pandemic that are on these slides. And I think the one that I always highlight on this slide is the HIV/AIDS, which I'm sure my colleague who is infectious disease specialist knows that that's an ongoing, pandemic that's still existent, although well managed with lots of medications that are now making it very stable. So this slide you might have already seen, and I won't spend too much time on explaining the coronavirus, which has become something that we are all a bit more familiar with than we thought we would be. So it's a lipid envelope, single-stranded RNA virus, and it's got these club-shaped projections, which is where it gets its name, like crown-like. And in terms of physiology, the SARS-CoV-2 virus binds to ACE2 receptors to enter the cell. And early on, that was discussed as like kind of in some physiology, and just as the news and media, there was a lot of talk about what that meant for people who are on the ACE inhibitor. So again, lots of things that have kind of evolved from what we know about its physiology. I like this slide because it makes me understand some of the symptoms and the variations we're seeing in patients. So the indirect pathogenesis of SARS-CoV-2 infection, and this is pathological changes and virus antigen expression in the lungs of SARS-CoV-2 inoculated macaques. So this is an animal study. But, I'm not a pathologist, but for some of us who have seen this in different times of our training, it's not hard to pick up on some of the thrombosis, some of the inflammation and ischemia, and vasoconstrictions of vessels. And the fact that it's related to some of the vascular anatomy is kind of how it's got all these different symptoms that we're seeing and different variations. But this just kind of helps to see why there's so many different presentations in some more severe condition, and then there's the ones that are asymptomatic and less severe, which actually is more relevant to the population of pregnancy that we're going to be talking about. I'm not going to dwell too much on this, but just to explain that the SARS-CoV-2 needs to bind to type 2 pneumocytes, then use its cellular machinery to replicate, and then that's how it releases the virus to the alveolus, and then the immune response is triggered. And then it attacks neighboring cells. The virus will be present in respiratory droplets and secretions because of the way it's going to be affected into the system. These we're fairly well aware. I just have them there because of different use of this presentation, but the symptoms may appear 2 to 14 days after exposure, and fever, chills, cough, fatigue, muscle aches, and then the less kind of GI symptoms that have been added on, but actually more relevant to pregnancy. And we'll talk a little bit about that. And then testing currently in Ontario is using a PCR reaction test. I know there's a lot of other tests that are being investigated to see if they can be more rapid, but although some were initially approved, have been since kind of taken off. So the Spartan Cube, if you're familiar with that, was being assessed, but there's still some issues to work out with the testing for a point of care quicker result for now. This is a slide that was published in JAMA in early May. It's not a pregnancy specific, but I like this slide because it's what we'd hope to find one day for pregnancy if we have enough samples and studies, which is what's happening to the virus, what's happening to the antibodies, and how it may be different in studies. And the way I explain this to students or residents when we review this is, we kind of have a story that we can tell with parvovirus and some of the other torch infections that we have in pregnancy. This may be something we need to understand related to coronavirus, or we may never get that story because it may be just a transient kind of infection, and then we don't ever really have that information. But we don't really understand what the timeline is and whether there is IgM antibody or IgG antibody prevention in pregnancy, so specifically. And so that's where some of the studies hopefully will be focusing on. But in this JAMA article in non-pregnant patients, what they found is that you can detect the virus really kind of a week after onset of symptoms, and you won't detect it in the pre-phase. And then after that, when you look at nasopharyngeal swabs, you'll still detect it for up to 4 weeks, and then maybe in some cases 5 to 6 weeks. In terms of IgM antibodies, those are the first that'll get picked up, and they here in about a week and a few days later, and can be picked up in sampling when the study that they looked at. So later after 6 weeks, and then IgG starts not much later, about a day or two, and then kind of stays on further, as we know, because it's the long-term immunity. However, having shown you that slide, it's important to know that there's still a lot of issues with IgG and IgM serology, which is why we haven't seen anything as far as I've seen up to date with regards to antibody testing in Canada. I know that they're working with Health Canada, with some virologists and labs to see if they can find the right test that we may use, but for now we haven't identified that. Yes, they are being used in other areas in the world based on just how their differences are in their healthcare systems and how they take on testing, but there's certainly a lot of variations in specificity, 80 to 95%, and the sensitivity with regards to IgG increases with time and symptoms, and it's very variable from 40 to 95%. I skipped to the antibodies because we were talking about it before on the slide, but the first part is to remember, which I know many of us are aware, that there is a false negative rate of up to 30%, and the sensitivity is 70%. And it may be related to disease severity based on what's shown in the literature. Electron microscopy has also been published with regards to the SARS-CoV-2 virus, but it's not really clinically relevant. It's just that we know that we can see it and identify it. So when this first started, many people were concerned that this would have a detrimental effect on pregnancy, given what we know from previous outbreaks like SARS and the MERS, which are coronavirus family viruses, where there was a more severe effect in pregnancy because of what we know about pregnancy physiology, which is that pregnant women are more susceptible to respiratory pathogens and pneumonia compared to those who are non-pregnant. And this is due to the changes that allow pregnancy to be successful, but like edema, respiratory tract mucosa, diaphragmatic elevation, and this can be more important in third trimester in terms of disease that can be presenting then, and increase of oxygen consumption, and then the pregnancy-related immunoalterations, which can make them more susceptible to infection. And then these same changes allow women to be less tolerant of hypoxia. So we still tell patients all the time, although we've seen that women who are infected with COVID-19 and pregnant seem to be at the most part doing okay, we still want them to be isolating and really following all the guidelines more strictly because of certain experiences that we'll talk about, whether with some severe outcomes. So this is a graph kind of more summarizing some of these changes that we talked about. So the diaphragmatic elevation, the effect of the gravid uterus, which for anyone who's been pregnant, that you can understand that that does add challenges to breathing. And then, the less long volumes, increased secretions we talked about. And just a reminder, when we're interpreting some of the tests that we'll talk about, including a blood gas, that there are changes that are related to pregnancy physiology that we need to take into account when we're reviewing a blood gas drawn on a pregnant woman who may need it because she presents with COVID-19. So this is where we kind of delve into more pregnancy-specific part of the talk. I don't see any questions, or if there's anything here, I could take a quick pause. It takes a little bit, but it sounds like there's nothing because I'm not hearing any questions from our moderator. So, so pregnant women are not more susceptible to getting the infection in general, other than the comorbidities or changes related to pregnancy we discussed. Most so far affected, so 75 to 80%, make a full recovery and are either asymptomatic or very mild illness. And based on the cohorts that have been published, we identified that 15 to 20% will develop a moderate to severe illness. And the most common presentation at the time where I prepared the slides was still fever and cough. And I've added a few slides from the publication from the UK Surveillance Network, which was published last week on June 8th. And I think that I do have those slides, but it's still cough. That was still one of the most common presentations, but we'll see all the other symptoms as well. And the comorbidities that increase the risk of illness are similar to the non-pregnant populations: diabetes, hypertension, having preeclampsia. And just a note that preeclampsia and COVID severe infection can be mimicking in certain cases based on some case reports that have been published. Body mass index, asthma, and immune suppression. The majority of reported cases have been in the third trimester, so over 34 weeks, and the mean gestational age has been 37 weeks, and that's still consistent with newer cohorts being added on. I wonder if this is not because that's when they're more infected, but related to when they may be presenting to hospital more often, because that's when we increase our care, and that they're questioned and then are tested and identified. So I wonder if there's a bit of a bias in how we're picking up these cases in the third trimester, because that's when they're more likely to present to hospital, or they have more clinical assessments being done in the third trimester. This is a hypothesis. I wouldn't want to kind of, but I do wonder if there is a little bit, because I don't think that you're more likely to catch it in the third trimester than in the first or second, because the infections can occur at any gestational age, and this is based on reported and our own local experience from some of the cases we've seen. Certainly no data to clearly suggest the risk of spontaneous miscarriage or teratogenicity. There is some case reports about miscarriage in second trimester miscarriage, but again, there are very few cases and difficult to interpret right now, to be sure. In terms of like just going, there's a slide on screening here that I didn't really put through because we've all kind of gotten used to screening, right? We've, all set up our guidelines and local hospitals in terms of screening and, kind of restrictions, and lots of policies were rapidly put in place in all our units to, make sure that we're keeping our staff and patients safe. When I explain this to some people, because a lot of variations in what there is in terms of care and what people are doing right now given the pandemic, but in obstetrics it's really hard for us to slow down or limit what we do, because we can't really stop laboring patients. We can't really not continue following these pregnancies. So we've had to adapt very quickly. And I'm sorry, I meant to put up a slide here, but if anyone has any questions about how to set up virtual care, and if you're your prenatal care provider, there is a really nice article in AJOG through the Society of Maternal Fetal Medicine that was just recently published, and they've got a nice table on kind of examples of how to space out and how to do some virtual medicine with prenatal care. And so I think if some of you are looking for some adaptive protocols, that would be a good resource to use. And I didn't add that slide, but I meant to, but I think it would be helpful for anyone who's trying to kind of going forward set up how they manage their prenatal care. Typically what we have been doing is we still see, I'm a maternal fetal medicine specialist, so I don't see them patients typically early. They're usually screened and seen by the family practice or obstetrician sometimes based on risk, and then realize that maybe they do need some care with us or some shared care model. Then we'll see them at around 12 weeks. We'll only intervene earlier if there's some emergency, and then to guide with some either dating ultrasounds or management and medications that may need to be started or changed. Then what I've been doing personally, especially when the pandemic was a little bit more acute, I would skip the 16-week visit and do it by phone or virtual, and then bring a patient back for a 20-week, 18 to 20-week morphology ultrasound and visit. And then based on how they were doing and how stable they were from like a medium to high risk kind of component, which is how I sometimes try to triage my own practice, I would skip the 24-week and call them and see them at 28 weeks. But if there was more major concerns, then I would, we are following guidelines and have PPE, so we would make them come in more often. So things for moms who need blood pressure monitoring, we've talked about having them buy the blood pressure monitor at home so that they can tell me their numbers so that we can review assessment. And so that's made that 24-week visit being fairly doable virtually, and then a 28-week in person. And then I've been skipping the 30-week and doing virtually, or having a good discussion with the mom based on what they want to do, seeing them at 32 weeks, 34 weeks, and 36, and then doing one virtual, one in person after 36 weeks if they're stable. If there's fetal concerns, then I did see them weekly. So just if it helps for people. But as I said, I would reach out, I would go look for the AGOG article about prenatal care models with using a virtual approach, and I think it can help as well to have other ideas. So that just was an aside before going through triaging patients who are positive with COVID-19. And I'll pause for a second to see if there's any questions about that discussion I had without a slide. Gonna make sure that I'm not missing something being typed here. I'm just gonna check this. Okay. Okay, so I don't see anything, so I'll go back. Sorry, I know that there's a delay, so I just wanted to make sure. So in terms of you have a COVID-19 positive and what to do with them and whether they fall into mild or the more severe illness, then you're going to triage them based on their vital signs. So if their vital signs are stable, as for our usual parameters, that they don't need oxygen, they have no shortness of breath or work of breathing, and that they're suitable for phone call follow-up with the primary OB care provider, which could be midwife, family doctor, or obstetrician or high-risk physician. I think if they are COVID-19, just on a side note, it would help to have at least a consult or a phone call or an e-consult with an obstetrician or a high-risk physician, just to make sure that nothing else is missed to support you in taking care of that patient. And then if there's no acute obstetrical concerns and no other comorbidities, then they can be discharged home and given a lot of instructions about isolation and quarantining and avoiding contacts and how to be at home with their family. Public health can be very helpful with those resources as well. Reasons that you would need to admit those patients are if they have more burden of illness on assessment and other comorbidities. So shortness of breath, unable to walk across a room, speak full sentences are things that you can do to test those. Coughing with blood, chest pain, signs and symptoms of dehydration, decreased levels of consciousness, oxygen saturations with less than 95%, and then a chest x-ray that has pretty severe pneumonia features because that may need more monitoring in hospital and some other management. So if you're sending someone home, you do not likely need to do more than having had the COVID swab that was positive. You don't need to really do any other blood work unless you're worried about other comorbidities. If you are admitting to hospital, then you should be screening for other blood work and features of signs of worsening. Sorry, I have a toddler who's unhappy crying in the background. I'm going to ignore her. So the listed labs I have here are routine blood work that of electrolytes, creatinine, lactate, prognostic blood work that some of these can be variant, and I would speak to the COVID-19 units in your hospital to see what they're ordering. Like I can tell you at the Ottawa hospital, there's a COVID-19 panel that's being put into Epic, and that's what's ordered on every admission. And it includes CDC, PT, PTT, NIR, CRP, LDH, ferritin, fibrinogen, D-dimer. I think there may be others that may have been added on since I looked, but those are some of the main ones. Lactate in the venous blood gas, and then if it's abnormal, then you can do an arterial troponins, especially if there's chest pain or any cardiac concerns. From a pregnancy point of view, understanding the preeclampsia, masking, mirroring, it would be important to also do urine protein creatinine ratio and uric acid or urate. And then considering cultures, if any concerns of other co-infections, or if they're just being worked up for it, you may want to swab them for other agents as well, not to miss other infectious pathogens. An ECG and a chest x-ray. And the CT scan is only needed if clinically indicated to rule out PE. And we've had cases where that was important to do. So certainly, just like with any risk of anyone who in pregnancy, you're worried about a pulmonary embolism, then a CT is absolutely safe, because that's always the concern is the imaging and the radiation. But in these cases, it is important to get the scan and have the answer, because it can be very poor outcomes if we miss that. And then the consultations of infectious disease. In our hospitals, we have OB medicine subspecialists, and then ICU being aware of patients in case they deteriorate. So in our hospital, we have the RACE team, which is someone you can call before they go to the ICU, and they can be very helpful with sicker patients, or at least to be aware. And I didn't add anesthesia there. And of course, they would actually need to be involved and aware of a more sick COVID-19 infected mom. I want to also point out here that given the rapidity of all of this pointing, some of these have not been created alone. There's been a lot of teams in Toronto as well who've worked on this and published some of their resources and held webinars. And a lot of this information is also from that information, which was excellent and was very helpful to help with the provincial guidelines on COVID-19 and pregnancy, which was also just, I think, 3 weeks now published. So if you haven't familiarized with them, they're also a good resource to access. So in terms of the warning signs that we're looking for when they're admitted is new use of oxygen, respiratory rates that are increasing despite having O2 sats are also important to keep an eye on, increasing amount of oxygen to maintain oxygen saturation. And those are all kind of warning signs that have been felt to be kind of signs of deterioration related to COVID. And so if you're on oxygen initially, kind of a 1 liter, 2 liter, but then you're increasing by 50% over a period of hours, then that's a concern. If you're desaturating below 94% despite O2 support, that's also a concern, and it is important to keep pregnant moms above that 94% saturation. And if you're on over 4 liters of O2 by face max, then those are also when it becomes more serious. And we need to keep closer eyes, and whether these moms are on the ward, we may need to have a discussion as to where they may better be monitored at that point. The other thing to be aware of that is very helpful when you're trying to triage a patient and look for a warning sign is the use of the MEOW score, so the maternal early obstetrical warning score, which is used in sepsis and is also very applicable to use in these patients. So then you can use these parameters for normal values, for when it's a yellow alert, for when it's a red alert, and then these will trigger when you need an MD evaluation, whether you have 2 yellow alerts and a red alert. So I think those help to guide how we watch these patients. So there's a lot of questions that came up when we, at the first few slides, I talked about thrombosis and pathophysiology as to whether we need to thromboprophylax these women. And when patients are admitted outside of pregnancy at our current COVID unit at the Ottawa Hospital, they are going on a thromboprophylaxis regimen that was put in place. Therefore, from that, we can extrapolate that if you have a pregnant woman that is admitted to hospital, that you should put them on VT prophylaxis, and you can either follow the same guidelines that the hospital is using for COVID patients, or the ones of the once daily low Vinox low molecular weight heparin 40 or 60 based on weight recommendations. And this is all based on, we know that COVID itself is a possible hypercoagulable state based on publications and case reports in pregnant patients, and more so in the non-pregnant. And so we know that the use of inoxaprison can likely decrease mortality in patients with severe illness. And so with women who are admitted, we are recommended VT prophylaxis, and the duration depends on how long they're admitted in clinical scenario. When they are being discharged, we are not continuing the thromboprophylaxis. We have a discussion with the patient. We see what they're going to be doing and then kind of go from there. I have used aspirin in some of these patients when they were discharged home antepartum, just based on, our head, kind of clinical experts discussion around each case by case, where aspirin is used in pregnancy for many different things, and it shouldn't cause harm. And if it helps minimize her risk of having a thrombosis event, then we may use it, especially if they're in the third trimester. In terms of postpartum, if they were a recent infection, I would consider prophylaxing them in hospital, especially if they had a C-section, and then consider aspirin used for 4 to 6 weeks. And again, this is just based on our kind of clinical recommendations. There was a lot of discussion around Celestone when this all started as well. There was very low quality evidence, author's opinion that, you know, maybe we should be careful because of corticosteroids maybe worsening initially thought in certain studies with COVID-19. And, you know, very clear example of how we have to be careful with everything coming out, because we just yesterday heard new evidence, not published data, but a news article on potential evidence of dexamethasone from a large trial in COVID-19 infected patients showing improvements in severe illness. And so I think that that's very promising, and it kind of makes sense clinically. And so the reason I bring that up is that I think it consolidates what we've been saying, that if you need to use Celestone for pregnant women who are at risk of preterm birth and they happen to be infected with COVID-19, then we have to continue using it because there's benefit for the baby that is proven. So if there's an identified risk for preterm birth, we will use it. We won't use it after 32, 34 weeks, like some kind of more evidence comes up for late preterm for obvious reasons, where at that point the benefit's not as strong. So the other agents to discuss, so there was a lot of initial discussion again around anti-inflammatories and whether they worsen COVID illness. So we typically don't have to worry about it too much in pregnancy because we don't tend to use them aside from for tocolysis, which I'll address later. So that's easier, so we can just refrain from use in pregnancy. In postpartum use, moms who were recently infected, we withheld it, to be honest, initially, and found them that they were having, this is again based on a few cases, but just our experience has been that they had difficulty with pain management. So then we added back the aspirin, the anti-inflammatories, and they did much, much better instead of taking Dilaudid or hydromorphone. So again, it's case by case, but there was a consideration to avoid it. And what we did with the patients that we put them back on, we used it less frequently, and it was enough to help with their pain management for sure. But there's certainly, you know, at the time, there's still insufficient scientific evidence to avoid NSAIDs, and I think there's newer studies that have come up to suggest that as well. So I think that's helped a little bit with that question for postpartum pain management. With regards to aspirin, we would still continue using it for the patients who are on it because of preeclampsia risk and IUGR risk. So we wouldn't change anything there. As I said, we could consider it for thromboprophylaxis, given its mechanism to support that for COVID-19 infected, and this is just to minimize any risk. Given that endomethacin is a tocolysis, and there's really no proven benefit with a lot of tocolytic agents, we do try to use them to give Celestone or for transfer. At this point, if you have a COVID-19 severely infected patient and you have preterm birth risk and you want to use tocolysis, you probably may want to use a different agent. And then just how to, you know, clear your cases. So for this, we will just kind of use the same approach that is used by public health recommendations. So this is the latest that I had, and I'm hoping there's nothing that's come up since the last 2 weeks, the COVID-19 recovery algorithm that we are been told, instructed to use. So there is the non-test-based approach, which you can use for community infected patients. Once they've been hospitalized, you do need to use the test-based approach. So with the non-test-based approach for community cases who have recovered from mild to moderate illnesses, you discontinue isolation 14 days after the onset of symptoms. For patients who had severe illnesses and were hospitalized, who are being discharged from hospital, they need 2 consecutive negative tests at least 24 hours apart before you can kind of clear them. So in terms of delivery consideration, having a COVID-19 infection is not a direct indication for delivery, and that's really important. The important thing is to take care of the infection in the mom and to stabilize the symptoms and address them with hydration, oxygen, antibiotics if you are treating for concomitant, if you're protecting for concomitant community-acquired pneumonias. A lot of our patients on the COVID-19 ward at the Ottawa Hospital are on different clinical studies, and the pregnant patients were recruited for those same studies. So they can be consented and choose to go on some of these clinical trials based on different agents that have been used. So they can be managed as from the non-pregnant population. The decision to deliver itself is definitely individualized and may need to happen based on the maternal and fetal status and the gestational age. So here I can comment on a case, on a first case we had. She was near term, 35 to 36 weeks, presented with increasing oxygen requirement, increase in rest rate over a quick course of 24 hours of her admission. And she was desaturated, even on oxygen, just going to the bathroom when I was speaking to her. So we had a big team meeting about her with anesthesia, internal medicine, ICU, and all the people who are involved with this decision-making and care. In her case, just to add to why it was maybe easier to make those decisions, she'd had a previous C-section, so she was going to be a repeat C-section, and that's what she wanted. Because she was worsening and we were concerned that she might be hitting the peak of when her severity of her illness may be increasing, we made a plan to deliver her by C-section in a very planned approach. And it was the right decision for her. She got much better once that gravid uterus wasn't pushing up and affecting her breathing, and very quickly didn't need any oxygen postpartum within hours, and ended up, going home within 3 days postpartum. And it was good. So for that patient and that discussion, it was, an individualized plan that was the right answer. While, someone who's less than 28 weeks, you would want to management, you would want to treat them, and you may mechanically ventilate them if you need to support their breathing because you want to continue and maintain their pregnancy. And, getting to a delivery is really because you're not able to ventilate them and you're not able to, protect their airways. And that's when that may come into play, where you might want to have an earlier delivery. So really, it's around their mechanical ventilation not being able to be maintained. That's when you would deliver to really support the mom at that point. Fetal monitoring is not necessary if mom is fairly stable, but if there are any abnormalities that were detected on screening, non-stress tests that were done on admission, like tachycardia or minimal variability, then you might keep them on more monitoring. Otherwise, daily routine monitoring after 28 weeks would be appropriate. Prior to that, you could do auscultation-only surveillance because they're earlier gestational age. And it is important to note that delivery itself may not improve the maternal disease, but may facilitate ventilation, and that's why we make those decisions. And don't forget that if you are delivering below 34 weeks, we talked earlier about still trying to plan Celestone if possible and allowing that 2-day kind of delivery of Celestone to optimize fetal lungs if the mom is stable, and giving magnesium sulfate for neuroprotection when you're delivering early, and doing that slower over an hour to limit maternal respiratory depression. I'm pausing quickly to see if there's any questions.
No, not at this stage yet. It's great, thanks.
Great. Okay, great, thanks. We joked in the beginning of this, just for anyone who hasn't done the live event, that it's an interesting place where you feel like you're talking to yourself, but starting to get used to it briefly. So the key points for antenatal management of pregnant patients is screening. So making sure you're screening with vitals and make sure that you identify. So this is just in an antenatal ward, so now non-infected patients in general on our floors. And then making sure that you're aware of anyone who develops any symptoms that would require them to now be isolated and then be tested. And that's what most units are doing. I mean, we have a screening at the hospital entry just like everyone does, but we also have a second screening at the entrance to our labor and delivery. And we chose to do that by asking more detailed questions to make sure we could identify anything that could be a risk factor, so then we could appropriately categorize them, isolate them, and test them. And so this way we don't have any risk to our healthcare providers or to other patients. So the things that we need to pay attention to are temperature, and we know, and I'm sure if you've been this, it's so tricky in labor because we get fever in labor fairly commonly. So yes, we do get a lot of patients who get put on isolation where we know it's related to other things, but at this point, we don't really feel like we want to miss any cases. So we are screening and isolating anyone who develops a fever in labor at some point during their admission. We will try, first to make sure that there's nothing easily correctable, like giving a bolus, rechecking the temperature. But if there's still a consistent fever, then we will do the swabs for COVID-19. We will initiate droplet precaution. At the height of the pandemic, we were actually, unfortunately, sending the partner to leave at that point. Now we are letting them stay, but then they have to kind of isolate until we get the test results. So we've adapted a little bit and lifted some restrictions with regards to our policies for the partners. Then if there's more involved in terms of symptoms and comorbidities, we would order the investigations that we've discussed, consult appropriate care providers if we felt the patient was worsening, and increase our surveillance. If the swab is positive, then now the roommate is a contact, and then we need to, make sure to isolate and continue droplet precaution. And this is kind of a little bit more of a summary. At this moment, this was actually a discussion after we gave local grand rounds with our colleagues from midwifery and whether we, recommend transfer of care or place of delivery. And I think at this point, given the disease severity and what we don't really know, hospital birth is probably the most appropriate so that the neonate can also be assessed and seen, and just to make sure that we don't miss anything. I don't think that necessarily means transfer of care because there's many models where there's midwifery privileges or family practice in hospitals, so those can continue with the usual care provider and only transfer if there is more severity or for, as usual, obstetrical indications. With regards to fetal monitoring, that's not necessary to be continuous. However, there has been some reports of fetal compromise, so again, to use it based on severity of the mom's illness and other vital signs that are assessed. And again, mild symptoms, which we discussed, and then if moderate symptoms exist and more severe symptoms, then you need to maintain mom stats over 94%. Checking their fluid status. We don't recommend hydrotherapy or water births because of feces and risk of co-infection and in the feces and rectal swabs that have been identified. We are encouraging epidural anesthesia, and I know that there are some smaller centers that have recommended epidural anesthesia because they're concerned about risk of urgent general anesthetic if there's an urgent procedure. And I don't think that's unreasonable because we want to be safe and we want to minimize just a general anesthetic risk. Currently, there has been no evidence of the presence of the virus in vaginal secretions and amniotic fluid in the tests that have come up in the literature. So you can continue doing fetal scalp electrode or scalp lactate sampling as per usual obstetrical indications. We have stopped using nitrous oxide masks for pain management because of the risk of aerosolization. But as we cited, it's not an indication for delivery and not an indication for cesarean delivery, only if there's obstetric indication. And again, not an indication for induction of labor. You would follow your usual induction of labor recommendations. However, if you're in labor and there's shortness of breath and more increasing hypoxia, they're in the second stage, you could consider an assisted vaginal birth to shorten the second stage, or a passive second stage if applicable, just like we use in moms with cardiac disease. I think we've talked about the fever, so I'm going to skip this slide. And just the only thing to add here is don't forget about our usual care of workup for chorioniana, is not to miss those in the pandemic, which may shadow kind of everything else we usually do. And then if some of you use misoprostol for term induction of labor with rupture of membranes, the doses that we're using there should not give maternal temperature. So I would still follow the same process if you see a fever in those moms. In terms of delayed cord clamping, there has been no evidence of the virus in the cord blood based on what's been reported. There's so far limited evidence of vertical transmission. However, there's some case reports for either side, and we'll talk about briefly later. So you can do delayed cord clamping, supporting breastfeeding, skin to skin, any direct baby care with appropriate mask use if they're infected. And there's some really good guidelines in that ministry report that was published to help with guiding mom on how to take care of a baby and how to clean her breast prior to feeding if she is COVID infected. I'm going to skip this slide to say that, you know, this started with the China experience where they published their experience of 18 cases. Then we had the New York publications that all have been fairly consistent in terms of epidemiology. So I'm going to use this slide more because it's an illustrative slide, so it's easier to follow. So this is the New York cohort, and they had 43 COVID-19 infected patients. Of those, 29 were symptomatic, 14 were asymptomatic. And this is important because the New York hospital is one of those that started doing universal screening, and that's how they picked up some of these cases. Of the 29 who were symptomatic, 26 had mild disease and kind of recovered either with outpatient management or was admitted because they were obstetrical reasons. Only one of the mild disease ended up being severe and needing treatment. And in their case, they were using hydroxychloroquine. And then from the initial 29, 3 were more severe, and then different regimens were used for each patient. So do you see how case by case they were? From the asymptomatic, 2 of them ended up having critical disease and ICU admission, which I find very interesting because these were patients who initially were screened and from universal screening and were asymptomatic, but they were some of the sicker patients. And actually one of them was discharged home and recovered. However, one at the time of publication had still remained an inpatient and was quite sick from when you read from that publication. Everyone else kind of had mild disease and recovered, which is where the number of 15 to 20% of pregnant women become critically ill has come from and has been consistent with other cohorts. This is the study that was just published last week by the UK surveillance group. The UK surveillance group is an obstetrics infection is set up and just kind of reinitiated when the pandemic started. And that's actually wonderful because I think they have a very organized approach to this. And so they have 427 cases that have SARS-CoV-2 infection between March and April 14th, which is a lot more than what our regions are going to see. As we're chatting before we started this round, I think that you know, we have done overall fairly well in Canada, and we haven't seen big numbers in pregnancy, which is great. But some of the European and US have seen more cases. And what they looked at is prevalence. And so 4.9% of estimated incidents of admission to hospital were infected with SARS-CoV-2 in pregnancy per 1,000 maternities. The other important thing that's rests on this slide is the maternal symptoms. So fever and cough, breathlessness, those 3 still top 3. Diarrhea, vomiting, certainly symptoms that are more common in the pregnancy population. You won't see these as high in the non-pregnant, but certainly there. But then everything else is fairly consistent with what we see. And this is more of the characteristic. The important part here is the ethnicity Unfortunately, this is consistent with what others are reporting in non-pregnant. Non-white ethnic groups are more likely to be affected by a SARS-CoV-2 infection in pregnancy. So rate ratio of 4 in Asians, 8.1 in Black, 2.7 in Chinese and other, and then 2 in the mixed ethnicity. And certainly it's hard to know for sure what the reason behind that is. If it's travel, if it's socioeconomic status, if it's other underlying pathophysiology, it's not quite clear. And in terms of the outcomes and needing critical care, 10% of women needed critical care, which aligns with the cohort that I described from New York earlier. And 24% had pneumonia on imaging. 1 needed more severe more advanced mechanical ventilation like ECMO. And the final outcome is 1% maternal death, so 5, which is always high. Any maternal death is high. 93% were discharged and well, and 6% were still at the hospital at the time of publication. So this is just more information on the pregnancy and infant outcome. So 1% pregnancy loss, 4. 3 stillbirth, 1%. Live birth rate is 97%. 1% rate of neonatal death, so 2. And then in terms of gestational age at delivery, most were after 37 weeks, so 74%. And then some in the mid, kind of late preterm stage, 32 to 36 weeks, 16%. In terms of mode of delivery, 16% delivered by cesarean sections that were related to SARS-CoV-2. And it's really nice that they broke it down that way. I really thought this was a well-published study, actually, if people are interested in reading it. And 44% was cesarean section for other indications. And then operative delivery, 11%, unassisted vaginal delivery, 30%. So certainly still a high rate of operative deliveries between either cesarean section or operative vaginal deliveries. In terms of the infants, and the infant outcomes show 25% neonatal unit admission, and these is likely the ones that were born earlier. 95% tested negative for SARS-CoV-2, and 2% tested positive for the SARS-CoV-2 virus less than 12 hours of age, and over 12 hours of age, 2%. And it's important to use the timelines because that's where some of all the information about whether there is or is not vertical transmission is around, is the timing of when the infection is picked up. A lot of the next slides I'm going to skip through because of time, and I'd like to get to make sure we get to more questions, but they just highlight all the case reports that have come out from different parts of the world. This one is from Texas and showed a severe COVID-19 where they suggested vertical transmission based on the fact that the neonate had positive RT-PCR very quickly after delivery by C-section. And so they felt because of that timeline, delivery by C-section, this could be a suggestion of vertical transmission. Sorry, I said some of the corresponding authors were from the US, but this is a case from Peru. This is another case where the antibodies showed up in the neonatal blood sera. And so then another case report or case series of 6 mothers affected with COVID-19. This was published in March in JAMA, and they felt that there is question about whether there is some vertical transmission, not necessarily with the virus itself, where it had all been negative by RT-PCR. None of them were detected in those newborns, but then virus-specific antibodies were detected in the neonatal blood sera samples later. So these are all the samples here and showing levels of IgG and IgM of the antibodies. Again, these are the antibodies that I've talked to you about being not the best tools yet, but this is what we're seeing so far in terms of evidence. This was another case where there was a positive IgM after delivery by C-section at 37 weeks of a mom that was infected at 34 weeks. And again, non-specific to know whether this is true or if it's other reasons that are causing this inflammatory response. either via maternal, fetal, or placental effect. We definitely need more long-term testing. At any of our group's research meeting, this is what we keep telling ourselves, and it'll be very important to see how this story will unfold. But the placenta has certainly been interesting with COVID-19 infected patients. We have seen changes in the placenta that are published that are very similar to preeclampsia and IUGR spectrum. And it's like concerning to see because some of these moms didn't have blood pressure issues or any blood work changes. But we're seeing inflammatory infiltrates, increased intervalent fibrin deposition, decidual vasculopathy, and some malperfusion, either on the maternal and fetal sides. And that's certainly very interesting. And a lot of it is still very hard to all kind of put together and explain. We have also seen the virus cultured from the placenta. So it's definitely where a lot of us are very intrigued and feel like there's going to be some findings that are going to be important to really put together and review. This is just a case report of an electron microscopy picture of the virion in the placenta, which has been since reported a few more times as well. Earlier, I talked that we don't feel like we know and have data to say that there is any first and second trimester effect in terms of teratogenicity. There's really not enough data to make any assumptions from it. This is just the case report I alluded to earlier that was published at the end of April by the Switzerland group who are very interested in this virus in pregnancy. And they comment on a second trimester miscarriage in a pregnant woman. It's hard to know for sure if this was related to the SARS-CoV-2, as you know, when we read this as obstetricians, sometimes we wonder if there was like a chorioamnionitis unrelated, but it's hard to know. But certainly that's one of the studies we have. And as stated earlier, so far, none of the studies of looking at amniotic fluid or breast milk has shown the presence of the virus. This is another case report, which I'm going to skip through, that actually shows that they didn't see vertical transmission. And so this is kind of where we're left, right? We're left with, is there or is there not vertical transmission? You know, vertical transmission can be bloodborne, which would imply viremia, which actually we do know that there isn't a lot of viremia in SARS-CoV-2 when we try to get it from the blood. And it's in more severe cases that it is identified. So this would be going against the fact that there is a transplacental vertical transmission. I think that's what we're going to find at the end of all the information we have. But whatever vertical transmission or cases are seen, which are very few, but there are some reported, are likely going to come from an ascending route. And so whether there's a break in the membrane or more inflammation that causes that the placenta or amniotic, the sac isn't doing as much to protect the baby from the virus, and that's how the baby is getting infected. So those are some of the theories currently thrown out there. As you said, in terms of like what is on the pros and cons list for vertical transmission, we know that viremia is low. We have seen negative amniotic fluid and vaginal secretion RT-PCR testing. We do see the presence in feces up to 30% in asymptomatic adults. This is a non-pregnant population. So we do know that that is possible for any vaginal delivery routes because we know that the close proximity, there's a risk of contamination. Then whether the mom being more sick is a higher risk to the baby with prolonged severe maternal hypoxemia, inflammatory cytokine storm. But, you know, the other things to remember is that fetal viremia is highly unlikely. It may end up being what I stated earlier, that there's an ascending infection. And so this is summarizing the same thing. This was an article published on this subject as well. And, you know, is basically summarizing again what I've just stated, that there's the intrauterine infection or a perinatal infection that can be due to vaginal delivery or other exposure, or if they're later, actually maternal, you know, exposure with their baby. And that's a summary of everything I've just kind of pointed out there. So I'm going to skip through that. In terms of breastfeeding and COVID-19 and recommendation, this is from the World Health Organization. Breastfeeding is an important kind of resource that we always still kind of want to promote in these moms. There is no difference there, and it can protect their infants from getting sick. So we do recommend it. If they are infected, then we will talk to them about, either if they're very sick, pumping and discard, or just cleaning their breasts and taking precautions and feeding their baby either to the breast or by pumping, and having a healthy provider give the breast milk is also appropriate if that's how they feel more comfortable. So this is another good place to pause, because I'm going to give you guys a quick overview of what our research group has been working on. But I do want to make sure, to answer any questions right now.
No, you're doing really well. This is very, very interesting. Why don't you give us an overview of what's going on at the TOH right now, and then we can go back.
Okay, I think that's a good idea. So I'm guessing your question is around like just the patient flow and the cases, just to make sure I don't.
Yeah, actually, so what's happening in terms of the clinical care or the clinical cases, and then sort of what's on the horizon for everyone there.
Yeah, no, that's great. So essentially, right now we are still, following all the precautions, regardless of what the phases of reopening are in the community. We're still only having moms come in for any clinical appointments, ultrasound visits at the obstetrics floor, and for triage visits and assessments. Once they're being admitted to the birthing unit, that is when their partner is going to be called up and can join the mother. He obviously has to pass all the screening questions to be able to join. Otherwise, he cannot come in. And so then he's able, the mom and family at that point, when they're admitted for delivery care, stay in hospital. There's no in and out privileges. And it sounds so bad. It's almost like a prison, but they can't leave, go in and out. We are providing meals for both parents, and then they leave when they're discharged home, right? So this is like for all our pregnant women coming through. And it's worked well to just kind of keep our units well. We haven't had any outbreaks really, except for that one at the Civic, which was not even an advanced pregnant patient, but regardless. So it's worked well. And for C-sections, initially, unfortunately, dads weren't coming into the operating room. And this was a preference from our anesthesia colleagues, just because of how they changed their workflow, and it was important for them. And I understand that. But now that things are slowing down, dads are now welcome back in the operating room, as long as they pass the screening questions with proper PPE, obviously. So that's kind of like a quick overview of labor and delivery. If there are fever, we are isolating, we are following the protocol that I explained to you, and testing for COVID. We're testing for COVID more than we did at the beginning of this pandemic. If a mom presents with unusual abdominal pain, nausea and vomiting, diarrhea, we will test now, because we've been given more with testing guidelines, and this allows us to just kind of make sure not to miss any cases, because of everything that's been published about asymptomatic carriers in the pregnant population. We feel like any opportunity that we should test someone, we do when they come in through our triage units. So that's kind of there. In terms of pregnant cases, there's about 11 cases of pregnant moms in the region that I'm aware of with COVID-19 at different stages in pregnancy, and only three have required hospital admission. One is not doing as well, but she has so many other comorbidities, unfortunately. The other two are doing well since discharge from hospital. I don't have it. Obviously, we think there's more cases that are asymptomatic just based on epidemiology, but that's just what we know. And the regional, like Ontario-wide, I would say based on the last born report, there's about 24 or 30 cases in Ontario at the time that was published. So I'm sure that's ramped up. And I would say most of the affected regions are more severely as in Southern Ontario. So that's kind of where we are at there. Does that answer the question? Do you think there's more clarifications?
No, that's great. I find it interesting how we were talking beforehand that your group is finding more cases later on, as opposed to the pandemic, as opposed to what we're seeing in the acute care setting.
Yeah, actually, it was fascinating, and I'll tell you my personal story with regards to that. We started embarking on the journey of wanting to do the study in March, to be honest, fairly early on. I work with an epidemiologist who published on the H1N1 pandemic and the SARS. So she kind of approached me and said, you know what, with what's going on, it'd be great to start looking at research ideas. And so we set up some networks for epidemiology follow-up through the BORN, which is a perinatal database in Ontario, and added some questionnaires there. But then started to develop, well, maybe we want to look at vertical transmission. We happened to find an awesome virologist at the University of Ottawa we partner with, and so we developed a team and wanted to look at this study workflow, which you're seeing. So we set up the COPE network, the COVID-19 Ontario Pregnancy Event, and then got it all going, got our ethics approval, and had no cases. And it was a little bit hard on us because as much as I guess we don't want cases, but once you've done all that work, we were like, well, maybe we're not going to get any. And I actually had someone comment that, you know, I think we're doing okay in Ottawa. Maybe you're not going to get any cases. And you know, at that point, it is what it is. But actually, our first case was in May. So just as we were thinking, well, we set it up, we've got other sites, and we were going to get samples from other sites that had more cases. We got our first case, and that's actually once they started. We started to get 1 or 2 cases identified a week since then. And that's, I guess, what brings us to the 11 cases I've talked to you. From those cases, 9 are involved in our studies. Obviously, patients have to consent to participate in any research, and some didn't want to pursue the study. So yeah, we are seeing more at the tail end. And I don't know that it's because pregnant women are going out more and less isolated, although it could be. You know, we had different, you know, spring and Mother's Day, and certainly from an epidemiological perspective, it could be how we had more cases pop up. Or is it because we're testing more on more like less obvious symptoms, and that's how we're picking them up? So it could be either one. So the next slide, I just want to always make sure to highlight how amazing the team that we have, because that's how we were able to do this work in a short amount of time. So Dr. Marc-André Langlois is the virologist lab that is doing all our testing of our samples. And Dr. Mark Walker, Dr. Jessica D, Dr. Sarah Lawrence, Dr. Bill Cameron, Dr. McGinty, Dr. Miller, our clinicians that are from different departments who are involved in supporting the study, and then more basic scientists like Dr. Bainbridge, Dr. Crawley, and then are the members of our team, Ruth Renix-White, Wilmina Thackeray, Alicia Harvey, Dr. Malia Murphy, and Dr. Catherine Muldoon. So I work with the Omni Obstetrics Research Group, and that's how we set up this work. We also have some partners at CHEO, so Dr. Brophy, Dr. Sampi, and Dr. Fell is the epidemiologist I mentioned earlier, who started us on this journey, and pathology to assess our placentas, which really have been interesting, is Dr. Dina Aldin-Alwali. Dr. Anne Sprague from Born Ontario, supporting our Born Registry network. And then we've been in contact with SOGC to make sure we'll have some dissemination of the information we have. And just like briefly, I just want to look at time and make sure. So these are the sites we have currently enrolled as collaborating sites that we're onboarding. It takes time to get all the contracts and stuff, but we're getting there, and we've got 3 sites, 2 or 3 sites, I think, that are ready to go, and then some that are in progress. I hope it's okay. I did put an email here because I can't formally announce all the detail, but we did get funding for this work, and it's going to be formally announced once that funding agency will announce it. So I can't give more detail, but we are then able to take on more sites. So if anyone here is listening and does have cases and wants to send us samples, I've left our email, or even you can send me an email, copenetwork@ohri.ca, and we would be happy to discuss if that's something that we could do. And so the rationale of our study is essentially to, in summary, assess whether there is any evidence of vertical transmission. And it is crucial to still do these studies because there is so much variations and different approaches internationally, and having a local, regional, and then provincial cohort is important. And we want to see if there's any concerns with pregnancy, delivery, and postpartum. We're also going to assess breast milk and combination feeding to see how the SARS-CoV-2 infections then do arise if they do. So we are looking at many sites in Ontario, and we're looking at viral load as well as antibody testing. The lab that Dr. Langlois does have testing facilities for the antibodies, and they're actually working on being a testing site for Health Canada, but that stuff is also ongoing, and he's also been funded to continue this work successfully. So the study overview is a multi-center design. We're going to look at confirmed or suspected cases because some of them may show up at that time of delivery and we wouldn't want to miss them. And because of the high false negative, we will still keep a suspected case that's consented to the study in our study population. And I'll explain to you a bit more why that's important as well. They have to be delivering in Ontario, and they have to be able to give consent for the maternal and neonatal sample. So we're looking at placental pathology, we're looking at vaginal mucosa, rectal swabs, amniotic fluid, placenta, breast milk, cord blood, and neonatal throat swabs. And we're testing for RNA particle for SARS-CoV-2 by digital droplet PCR. This is a different technique than what the ministry is using. There are some publications that show that it may be more sensitive, so that's what we've been working with at the lab we have partnered with, and I think it'll be interesting to see, because we are still reswabbing them, to compare with the ones that are used from the ministry swab. We'll also look at the neonates, and what we're looking at is the viral load, the serology, and then pathology findings. We do not need to take blood from the baby, just from the cord blood. That should be sufficient. We would only take blood work from the baby if the mom consent to it, and if there was real concern and need to then ask for blood at the time of delivery. Also, it's important to say that we know we can't get all of these samples on every patient, but what we've been trying to do is collect as many as possible and as many as the patient consents for. You can't always collect amniotic fluid easily at the time of vaginal delivery, and we're aware of that. And not all moms want to breastfeed. So just some of the ones that we are aware we may not all get. And the first objective of our study is really just to kind of see the mother to infant transmission by all the kind of summary slide here. And that's a better way of seeing it. The timing of collection is prior to delivery, like during their admission. Okay, we're going to take the swabs, and they do have to be in the same viral media. And then the amniotic fluid is either during delivery, or if you're doing a controlled rupture of membranes, it can be done, or at the time of C-section, we can aspirate it prior to delivering the baby. Cord blood can be done with the blood gases, and then post-delivery, we'll try to get a maternal blood sample for the serology. Placenta is done ex vivo, and then we do the neonatal swab and breast milk if mom is breastfeeding. The other thing we've added on now, since seeing more and more information, is we will be testing the baby at a month of age for a swab, as well as a blood serology testing. And we're hoping that we're only going to need very small blood as we're fine-tuning this. And this is based on recommendations that have come out worldwide for more studies to look more longer term on what's happened to the neonates, and especially the serology. And so like locally in Ottawa, Monarch is helping us to do those testing. And so that's where we'll send moms to go do the follow-up testing. Then this is the objective 2, which is the epidemiological study using the born data. So I don't know if many of you know, there has been, like, unfortunately, way too long addition for each case of COVID-19 and pregnant in Ontario that we're asking people to extract for the birth registry. And this would create that now it'll be available for anyone who has any questions on any COVID-related questions in pregnancy. And what we're going to look is obstetrical details, just their case histories, transmission patterns, and newborn outcomes. Another objective that's more longer term, but is being led by Dr. Fell, is going to be looking at matched pre-pregnancy patients, matched uninfected cohorts during the pandemic, and then COVID-19 cases, and try to compare their maternal newborn outcome and infant outcomes. And this will allow us to really see what the effect of the pandemic itself is on our patients, because there is also some literature around that from previous crises where it can affect inflammation and cytokine response in pregnancy, and that in itself can change your maternal and fetal outcomes. So just kind of an overview and summary. That's not what I want to bore you too much with. And the last few slides are just to comment on universal screening. We will try to implement universal screening at the Ottawa Hospital Department of OBGYN if we do get a second wave, to be honest, and that's part of the funding that we were able to secure. And I know that there's some hospitals who have been trying to implement that as well. It just depends on what resources and what the administrative leads have decided. Because it's such a busy unit still for care, universal screening can be helpful because it'll help us with, you know, resources with PPE and how we isolate patients. And, you know, certainly this is the paper that got us all thinking about it when the New York group, where, you know, mind you, we have to keep in mind this is a high prevalence area where they have been severely affected, showed this is the best kind of pie chart summarizing it, where when they started doing universal screening over a period of 3 weeks, it's March 22nd to April 4th, 84%, almost 85% were negative, 13% were positive and were asymptomatic, and 1.9% were symptomatic when they were positive. And certainly the concern there is that when you look at that, 87% of those who were COVID positive in that cohort were asymptomatic. And so they have been doing universal testing. Other sites in the US have published on their experience with universal testing, some with similar numbers, some with not. And, you know, some people then doubted what that meant as universal testing. But the reality is that you're going to pick up COVID infected patients based on whatever regional prevalence and incidences at the time. And so my last slide is just a summary that the nice thing about this is that what's been good in research is that I find there's been much more discussions and collaborative work, maybe because we've discovered how easy it is to have conferences and we've been setting more up. And it's nice to see that we are going to try to get as much of this data into bigger and bigger data sets to really try to get the right answers. So in Ontario, we have the BORN database that will look at the epidemiology, and we have the COPE network now in place for the vertical transmission clinical sampling study. We are involved and also collaborating with a larger Canadian group, the CAN-COVID-PREG, which is a Canadian COVID-19 and pregnancy surveillance group led by Dr. Deborah Money, who's an infectious disease and pregnancy specialist and has done a lot of work with HIV and other pandemics. And so that will allow all provinces to use their data and then kind of include in a bigger registry to get a Canadian cohort. The Canadian group, a lot of us are also getting REB and ethics approval. And so our center has to feed into the international COVID-PREG database led by Dr. David Bod, who's in Switzerland. And so this is, they published their first abstract. They're preparing for their next big wave of case series publication, I think in the next few weeks. And so we are also including our data into that cohort. And I'd mentioned earlier the publication by the UK surveillance group led by Professor Marion Knight. In the US, the priority group is also up and running for a pregnancy registry based out of UCSF by Dr. Vanessa Jacoby. So lots of good networks set up. And the nice thing is that they're hopefully not all separate networks and hopefully all feeding into each other to allow for bigger data sets and much better information to be analyzed. And I just want to highlight and thank our team, although this was hopefully the clinical outcomes, just from a research point of view, we can't do it alone. And so we have a fantastic group of people that have been working on the COPE network study, which were earlier presented. This is a nice picture. And if some of you are familiar with our department, Dr. Mark Walker is actually our chair, but is the co-founder with Dr. Shiwu Wen of the Omni Research Group that I work with. So that's the team that's been working behind the scenes to get this up and running. And I believe that's it. So I'm going to see if there's any other questions or discussion.
Yeah, there's a couple of questions, and they segue nicely into your last couple of slides. And two of them are centered around recommendations for pregnant patients or pregnant women or healthcare providers. And regarding avoiding the risk during pregnancy. And another question related to that is how you feel, or maybe the society feels, about the expanded guidelines for 10 people groups in Ontario. Is this something that the society would recommend that pregnant women participate in, or to be a little bit more restrictive?
Yeah, I continue to remind my patients to be restrictive, right? Especially since 15 to 20% is still fairly high in terms of pregnancy outcome. And then just how I explain to them, because you want to try to make sure you're getting buy-in, is that how much it'll complicate the care of their newborn and isolation from the rest of their family members. And I find when I kind of have that honest conversation with them, when they ask, when I reiterate, even on phone meetings, I'll always reiterate, we still want you to isolate. Although so far pregnant moms are doing okay, you could be in the group that isn't doing as well. So that's just my quick summary. And I know the earlier question is like, I still want them to be more careful in isolating and following all the social distancing precautions, wearing masks, especially because they're coming into our clinics, right? So I think it's scary to know that people are being. I know this almost feels like we've been let out of jail. We were joking earlier, and I think that there is still community cases. We are seeing them. Yes, there's less, but there's a risk of them reappearing and respouting, right? The BC has done amazing, and we all are familiar with that group of family, family get together where I think it was at least a dozen who were infected. The 10 people recommendation, so hard I find, because if you're going to follow it by the book, if I'm not mistaken, and you're an ID specialist, you can correct me, but my understanding is it should be the same 10 people. And if you are seeing other people, then you should be using socially distanced. Like that's what I tell someone. Asked me this the other day. I'm like, well, if that 10 people who aren't in your bubble, you want to just kind of catch up with, you might want to do with the 2 meters, 6 feet apart type thing with proper precautions, hand washing, and all the social distance measures that we've learned, because that's the only way we're going to continue seeing the downward slope. So I don't think we're done. I think we feel in the healthcare still, like our sonographers, our nurses all feel like we're still at risk. And so we hope that, I wish that, I do understand that society wants to kind of move forward, but that's the challenge, is that if they move forward too much, we're going to get in trouble again. I hope that answers the question, but that is kind of where the perception is. We're certainly not releasing all of our changes at the hospital until this is really over, because it's very hard to re-implement them. So I'm hoping that I answered the second part of that question. I can't see the chat box. I'm going to try to figure out how to get back to it. Let me see. Yeah, there we go. So just want to make sure. Yeah, I think the 10 people group, if you're pregnant, I think you need to be more diligent. Almost, I don't think you're in a high risk category, but I feel like that's what I would instruct my, the patients. Like, taking care of a baby when you're infected is not fun. Like, you want to be able to be safe with your baby, and I find I can sell them on that. A lot of questions about grandparents and visiting when they're not infected. And what I say is, if they're in your bubble, washing hands, maybe wearing a mask. I think that's, I don't know if you agree. I do think it's simple to do. I mean, we've gotten used to it. It is worth doing. Washing your hands more frequently, wearing a mask if you're close, or being safe distance. So that's kind of what I keep repeating. I do think we should screen for nausea and vomiting in first trimester. I do see that question. We have been. Yes, some of them we know are going to be hyperemesis, but until this pandemic is over, it is one of the tests that I do think we should add, and we have been. So yes, I had a patient, one of my patients, just to help if there's other questions popping in, presented with, diarrhea, 37 weeks, and like not feeling well and vomiting. And she was actually coming for a clinic appointment. So once they failed their screening, we isolated her. I told her, look, I think you might be in early labor, but I still got to screen you. So I screened her. She went home, it was negative. She delivered a baby 3 days later. Like, I'm telling you, the story is that what's normal is still normal, but should we still screen? Yes, because we have picked up some cases from weird things. Like some of those cases that I talked to you about were picked up with, one was a hyperemesis, or what was it? I can't remember. It's just GI, and another one was an ovarian torsion. Like it was just like, and I think we are being more liberated with testing, so that's what we're saying. Our residents are actually better than us as staff. They're testing much more readily. Oh, this is the symptom. I'm testing. If you had a headache, I'm like, okay, fine. And I trust them because they've been the ones that have picked up some of the cases. So
yeah, I agree with you. I think we need to increase our diligence a little bit in the testing. In the acute care world, we are having, because we sort of passed that first phase of the pandemic, and now we're starting to see our traditional patients come through. Maybe COVID's not entering our differential as high as it should be. So it's a constant battle to keep that in back of mind.
Yeah, and I think we need to continue it. We have someone who's going to come visit a family member from, so I don't mean to be biased, but from the Toronto region. That's a way to re-infiltrate our cases, right? It's that asymptomatic carrier that isn't following social distancing that will get it going. And it just takes one, right? As we've learned.
Yeah. So there's a couple minutes left. If anybody has any last questions, please send them. Was there an outbreak on the obstetrics ward at the TOH?
So as at the Civic, I can comment on it now. I didn't want to take up too much time, but it was declared an outbreak. It was actually the case of that I mentioned earlier. She was admitted with early pregnancy complications. It was early on in the pandemic that we missed her, like fever or whatever, and then she was tested outside, and then we realized she was infected. She was picked up later. So then we had to contact everyone who's admitted on the same floor, screen them, respace them, the staff. So we did treat it as outbreak because of the way it was identified. It was as an outpatient after she had just been admitted for, she was an ectopic. I wasn't directly involved, but something like that. And then she actually needed a surgery actually for her complication. But at that time we knew Verstatin, and it was done at the General, to be honest, our sister site, but with all the usual precautions because she was intubated and so on. Yeah. So that was the outbreak we had. We did have an outbreak at the Civic.
All right. Well, we're nearing our end of our time, so I don't see any other further questions on. I'd like to thank you very much for a very excellent presentation. I'm sure everybody else found it as useful as I did. And I'd like to thank all of our guests today who participated in the webinar. It's a beautiful day outside, so thank you very much for spending the time with us. Going forward, we are going to have more talks related to COVID and the post-COVID environment that we exist in. And so our next talks will be in the next 2 to 3 weeks, and announcements will come out. So again, thank you very much for your talk, and thank you everybody, and have a great weekend.
Well, thank you. It was great to chat with all of you, and I know you're out there. Have a good night.
Okay, good night.